Good evening, everyone. So first of all, I would like to thank the ACure committee for inviting me for this presentation. And it was an exciting day. A lot of advanced, sophisticated science. I was only able to digest half of the stuff, so I'll have to go back and look back at the slides. So essentially, I'm going to be presenting a clinical case, the idea of the door to unloading, which we were given approval by the FDA. It was a safety and a feasibility trial, and we were one of the sites. I'm going to just go over a clinical case, our experience at Hackensack. We have a patient, 62-year-old morbidly obese gentleman, remote history of smoking, who presented with pretty classical substernal chest pain an hour prior to presentation. His history, he did have a vague epigastric discomfort about 2 days prior to his index presentation, which spontaneously resolved, and now it reoccurred with a greater intensity. So exam, essentially, he was not in any kind of failure. He was hypertensive. His blood pressure was 198/103, a little bit tachycardic. Lungs were clear, and this was his original EKG. So as part of the trial, I was the PI for the site, so we get called from the emergency room anytime we have an acute anterior wall MI, and then the fun begins. So we have to go to the emergency room, and we have to discuss with the patient that we will be doing a feasibility study, which has not been done in humans before. So we have to be very careful with the choice of our words for getting the informed consent. And we have to say we have some animal data from Dr. Kapoor's lab, which have shown some benefit. And it's an interesting, humbling experience, because getting a consent for a very disruptive concept, which has not been proven. So for some reason, this patient agreed to, this was my first enrollment. I'm not sure why. I guess part of the reason was that the ED staff gave some reinforcement that, Dr. Faraz is a good guy, he is a good operator, he has good outcomes. So I think those elements play a big role in consenting in a very disruptive concept, which is kind of going against the norm of society, because we know angioplasty and door to balloon and 90 minutes it's a big theme. So we are kind of going against that. So once we consented the patient, and consenting is always a fun part, where Noam is somewhere here, because we have to get calls with Noam. We're back and forth. We have to randomize the patient. So we get access with the micropuncture needle, make sure our access site is good. And as per the DTU protocol, we do a left ventriculogram to make sure that there is no apical thrombus before we can randomize, and then the fun begins. So now the envelope opens, and we are told whether we're going to wait for 30 minutes on an occluded vessel, or we can go in and revascularize and unload the heart. So this particular patient was enrolled into the 30-minute delay arm. You can see there is a high-grade perforated lesion right at the proxy LAD at the bifurcation of the diag, and the flow is somewhere between TIMI 1 or TIMI 2. It's kind of very nerve-wracking for an interventionist to be standing there for half an hour and just sitting on an anterior wall MI. We all know that anterior wall MIs have pretty high mortality, and these are the ones that can turn into disasters. So it's kind of nerve-wracking, and we kind of did believe strongly in the basic science that that has been shown that there is benefit. But from a clinician's perspective, I think some of the stuff which I noticed in the lab while I'm standing there is, we did notice that the STs were resolving just by unloading the LV, which was a very, very humbling experience, because this is like life science you're experiencing. And the second thing was that the patient's intensity of chest pain was going down. So you're waiting there for 30 minutes and you're clinically observing, and this is like life medicine and application of life medicine. So it is kind of is a little bit reassuring that all the theories in the animal model is actually translating into real science, and we are doing the right thing. In the caudal projection, I have a wire in the LAD, and I do want to make sure I don't lose my diagonal. There's a Fielder XT. I had a little challenge wiring it to the diag. So we ballooned, LAD, diag, stented the prox LAD, and we had a very good result on the case. So this was the echo on the index admission. You can see the anterior septal wall is down. The calculated ejection fraction was about 43%. This was the MRI, which you can see the scarring in the distal LAD territory. So this was the MRI on index, and this was the 30-day MRI where I actually got a call from the radiologist who was a little surprised because he didn't see much scar tissue in the LAD territory. So he actually called me. He said, is this the guy who had the MI? I'm like, yeah, I think so. So the patient went home uneventful. Day 3, he was hospitalized, and just on our one patient, we did notice an improvement in the ejection fraction. I know Dr. Jarkoker had shown data about decline in the EF post-MI. So somewhat reassuring data. So as far as the experience of door-to unloading from the Hackensack perspective, and I think I was told to talk a little bit about the pivotal trial and the challenges. Again, it was a disruptive trial. We were going against the norm for the standard of care, and we were not able to enroll any patient for the first 80 days. Our enrollment criteria, we were doing the daytime enrollment, and after 80 days, we had to sit down, and we kind of changed our strategy to a 24/7 enrollment. So once we had a 24/7 enrollment, we were able to start screening patients more aggressively. We screened about 26 patients, out of which 11 met the inclusion criteria. So 2 of the patients refused to consent. 1 actually fell through the system. So challenges, again, I think it is a disruptive trial. It was very challenging consenting the patient, and for whatever reason, these 5 patients agreed and consented to undergo a trial. The choice of words for the PI was very important. We have to make sure that basically you are telling the patient that there is no data in humans, and you guys are the first guinea pigs that we are going to be trying it on. But again, the data from the animal model is very strong, and there is some signal that there may be a benefit. As far as the pivotal trial goes, I think this would need 24/7 enrollment, because I think daytime enrollment, we failed miserably the first 80 days of the trial, and then I think once we went into 24/7 enrollment, and Seth and Noam were getting calls in the middle of the night at 2 in the morning, it's important for systems champion, the PI, to be actively involved, and I think the biggest success depends on the emergency room staff, the cath lab staff, and the on-call interventionalist who has to coordinate with the interventionalist who is the PI. And I think at the end of the day, I think the administration has to be supportive because it's a systems-based approach for something that would be a little bit disruptive. Thank you.
Yeah, thank you very much for this interesting case. Several questions. Probably I can start with a question for you. I'm interested, how long the pump you let in this patient? You just fixed the anterior vessel and then
Correct.
You stopped?
So the protocol, we were leaving the pump for 3 hours post-reperfusion, and then we take it out 3 hours.
I think this is clinically reasonable, but when we think about that, what we have learned during the day, why only 3 hours? We think that unloading is important for all these inflammatory processes, which of course will occur and still ongoing occur even you have the vessel opened. And Michelle, probably you also can comment on that, all these reperfusion stress. Wouldn't it make sense, if you do not have any complications, to have the unloading longer on board?
I don't think there is, I don't know, I think Naveen is more apt to answering the question, but I don't think there is any clear data about the timing of post unloading for the time. I don't know, Naveen, I think I would defer that to you.
Yeah, no, it's a great question. I mean, we're obviously still under embargo, so we won't be able to share the results tonight, but, and we are a little out of sequence, so I apologize. I couldn't give the layout of the trial, but I'm about to do that now. So what I might suggest is that maybe I'll give that presentation, and then we can take questions, because then you'll understand the rationale behind the trial layout. Okay.
Okay, so we do it like that.
All right, thank you.
Thanks.